video is brought to you by drbarai. Please press on the subscribe button and the bell icon.
Hello everyone, this is Drbarai. I'm a consultant in the emergency medicine and also I'm a specialist in urgent care. We see cardiac arrest and periarrest scenarios all the time in the emergency medicine, in the urgent care settings, in the ward, in the theater. This particular video has been made to keep you updated about the various ECG rhythms that you can see or you may expect in a cardiac arrest or periarrest scenarios. These are time-critical, life-saving emergency. A very thorough knowledge, skills, and a lot of training are required. This is just a summary. This is not the one-stop shop. If you have any questions about these rhythms, please get in touch to your resuscitation officer. If you need further information, please drop me a line. If you have not done already, please subscribe to the channel and we'll keep you updated with the new videos on various types of cardiac rhythms and ECG patterns. So without further delay, let me show you the various rhythms in the ECG that you can expect to see in case of various cardiac arrest or periarrest scenarios.
So in cardiac arrest and periarrest scenarios, we can have a lot of different rhythms in the ECG. Some of the rhythms are there in the ALS algorithm, and some of the rhythms can be a bit unusual. We need to have a very good, thorough understanding of all these ECG rhythms to get the best available care for the patients. So let's show how these different types of rhythms are actually seen in the defibrillator machine, and also we'll talk about how we can manage these conditions. So this is the defibrillator machine that we use in our hospital. And in the monitor, you have got a few things. Obviously, you have got the ECG rhythm. If the patient is connected, which lead is there, that is demonstrated here. So for example, here we have got lead 2. The heart rate will be shown here and the oxygen saturation will be shown here. Here you will find the breathing pattern as well. Now this is the defibrillator machine which can be used both as AED mode, automated mode, or manual. So this is the on button. This is how the electricity is charged or detected. For example, here there is 200 joule. You can either decrease it or increase it. We start with 200 joule in an adult patient. This is a charge button. This is the delivery of the shock. Synchronize button. Pacemaker. If we want to do pacing, that is the button we need to press. For pacing, we can increase the rate, decrease the rate. We can set the amount of current that we can put on. For example, increase the milliamp of current, decrease the milliamp of current. Pause button. Alarm button, we can pause it. If we want to decharge the machine, we can press this button, and there are some other buttons as well. So to keep it simple, let's get into the rhythm straight away. As you can see, there is some rhythm here. Let me tell you about this patient. This is a 62-year-old gentleman who presented to the emergency department with chest pain, and obviously, he did not do very well. In the ECG, he has got some ST elevation. We were preparing to take the patient to the cath lab, but he then collapsed. His GCS was 3, no palpable pulse. He was unresponsive. And in the defibrillator monitor, this is what we can find. It is wide QRS complex, as you can see here, and it is irregularly irregular. It is busier looking ECG pattern, and that is called VF or ventricular fibrillation. As you understand from the ACLS algorithm, this is a shockable rhythm. So without any hesitation, we went straight to deliver 200 joule of unsynchronized shock. And he did very well. He has got a ROSC, went to the cath lab and has got 2 stenting in the coronary arteries and did very well. So as you can see that this demonstration of the VF cardiac arrest in front of you on the defibrillator machine can be very useful. Let me show you another patient. This is a 60-year-old gentleman who collapsed in the emergency department. Fortunately, the defibrillator machine was connected and we can find the rhythm here. This is wide complex tachycardia. As you can see, that QRS complexes are very wide, regular, and very fast. These are all the classic presentation of VT. There are maybe some other differential diagnoses. For example, it can be hyperkalemia. It can be an SVT with aberrant conduction. It can be a sodium channel blocking drug. But in front of us, when there is a collapse, and if we can find this, the first thing we check is if there is any palpable pulse or not. If there is a palpable pulse or is a recordable blood pressure, obviously we need to seek and treat the cause, for example, hyperkalemia or sodium channel blocking drug overdose. However, if there is no pulse and no recordable blood pressure, if the patient is in a cardiac arrest, we need to consider this as a VT until proven otherwise. And obviously, this is another shockable rhythm. So we delivered a shock, and the patient has got a ROSC or return of a spontaneous circulation and did very well. So this type of rhythm, we need to keep in mind that this is a wide complex tachycardia, regular, until proven otherwise, this is a VT. Keep in mind that this can be for some reversible causes, for example, a hyperkalemia or sodium channel blocking drug overdose. So these are the two most deadly rhythms that we look for in the defibrillator machine. Now, this is a very weird type of rhythm. We cannot see any QRS complexes. We cannot see any ECG pattern at all. However, this is not quite a straight line. This is a little up and down. And if we look at the patient, we found that this particular patient did not have any palpable pulse. Patient was unresponsive. So we declare this as an asystole. We started the CPR straight away, and we also followed the ALS algorithm. We have given adrenaline every alternate cycles. Unfortunately, they did not do very well. So this is a non-shockable rhythm, asystole. Now this looks like a pretty normal ECG pattern in another patient. As you can see in this ECG pattern or rhythm, there is a P wave followed by a QRS complex. So there is a P wave followed by a narrow QRS complex, an ST segment, a T wave, and followed by another P wave, QRS complex, ST segment, and T wave. The QRS complexes are pretty regular. The PR interval is pretty constant. So it looks like this is a pretty normal sinus rhythm. However, this 56-year-old gentleman came with severe chest pain and he collapsed in front of us. He was hypoxic, and in the bedside echocardiogram, he has got all the features of right ventricular strain pattern. We diagnosed this as a PE. So this pulmonary embolism caused this patient's collapse. Now, if you consider the rhythm itself, this is called pulseless electrical activity. So there is some electrical activity in the heart, but the patient does not have any pulse, does not have any blood pressure. He is unresponsive. This is another non-shockable rhythm, which needs to be treated with IV adrenaline 1 mg, 1 in 10,000 dilution, followed by CPR. Every alternate cycles, we should give adrenaline 1 mg, 1 in 10,000 dilution, IV rapid push. So again, the ECG pattern might look pretty normal, but we need to correlate this with the patient. Is there any pulse? Is there no pulse? If there is pulse, that's great. If there is no pulse, this is pulseless electrical activity. Obviously, we need to consider the 4H and 4Ts in this type of scenarios, whether it is a VF, VT without pulse, as an asystole, or a pulseless electrical activity. The 4H, these are hypoxia, make sure that we give oxygen 100%. Hypovolemia, make sure that we give fluid, normal saline, for example. Hypo or hyperkalemia, we need to do a blood gas, check rapidly the electrolytes, and treat appropriately. Hypo or hyperthermia, we need to check the core temperature and take appropriate measures. The 4 Ts are tension pneumothorax. We can use either chest X-ray or clinical examination, or a bedside ultrasound to detect that pneumothorax. The other T's are cardiac tamponade. Again, we can do a bedside ultrasound to detect the cardiac tamponade. Toxins. Appropriate management needs to be given depending on the toxicological overdose, and thromboembolism like myocardial infarction or pulmonary embolism. So these are the 4H and 4Ts. These are reversible causes for cardiac arrest, and we need to take appropriate measures to give the best available care for these patients. So these are the 4 deadly causes of the ECG pattern or ECG rhythms that we should look for in a patient with collapse. Let me show you some of the other interesting ECG pattern which you might pick up. This is a 17-year-old chap who was playing footy or football and has got a collapse. But when he came to us, he has got a GCS of 15. He had got a similar collapse in the past, did not have any previous ECG or echocardiogram, and this is what we found when the patient was brought into the resuscitation cubicle. What you can see obviously is the QRS complexes are extremely narrow, and this is sinus rhythm. There is a P wave followed by a QRS complex, P wave followed by a QRS complex, which is great. What is the alarming feature here is this little wave. This is a Q wave. We call this dagger Q wave. If you do a 12-lead ECG, you will find that in various leads in the ECG, these dagger Q waves can be demonstrated, especially in the inferolateral leads. This is a classic presentation of hypertrophic obstructive cardiomyopathy. This can be a life-threatening emergency. They can have collapse, they can have VT, even sudden cardiac death. These patients need an urgent echocardiogram and also admission to cardiology for an AICD or the defibrillator implant. So this is Hukum. This is another young patient coming with palpitation, and we put the patient to the resuscitation cubicle, connected to the defibrillator machine, and found this. If you carefully look at it, here the QRS complex is a little wide and the P wave is very close to the QRS complex. The PR interval is very short, which can be well demonstrated if we do a 12-lead ECG, but also there is a little delta wave which is just in front of the QRS complex. This is Wolff-Parkinson-White syndrome or pre-excitation, and they can develop rapid atrioventricular re-entry tachycardia. They can have orthodromic or antidromic conduction, and they can be life-threatening as well. So these patients must be consulted with a cardiologist, and appropriate measures should be taken. So this is Wolff-Parkinson-White syndrome or WPW. Now this is a very interesting patient I saw a few months ago. This patient has got recently diagnosed lung cancer. When we put the patient was brought in with shortness of breath, quite hypoxemic, tachycardic, and blood pressure was low. When we connected the patient to the defibrillator machine, this is the rhythm that was picked up. If you carefully look at it, there is a P wave followed by a QRS complex. There is a P wave followed by a QRS complex. There is a P wave followed by a QRS complex. So this is sinus rhythm, pretty regular. The alarming feature is the height of the QRS complex is alternating. Height of the QRS complex is short, tall, short, tall, short, tall. This is cardiac tamponade. I have got a separate video, actually quite a few videos on the cardiac tamponade and the bedside echocardiogram. And when we did the bedside echocardiogram of this patient, which shows a large pericardial effusion and the heart was moving side to side like a dancing heart. So when the heart moves in a rhythmic way, the QRS complex height can be short and tall, and that is called electrical alternance. If we do a 12-lead ECG, that can show a beautiful feature of this electrical alternance and the features of the cardiac tamponade. But the diagnostic test is not the ECG. The diagnostic test is an echocardiogram. So this is just to demonstrate how the electrical alternance can be demonstrated in your defibrillator machine. This is another interesting case, very rare, but this can happen. This is a young patient from Vietnam who was brought into the emergency department with a history of collapse. And this is what we found in the initial cardiac rhythm in the defibrillator machine. If you carefully look at it, there is a P wave followed by a QRS complex, and then there is an ST segment, and then there is an inverted T wave here. Now, the most alarming feature is this bit. So at the site of junction between the QRS complex and the ST segment, there is a bit of irregularity, a certain notch that is called epsilon wave. If you find epsilon wave in the defibrillator machine, ECG monitor, or a 12-lead ECG, especially in V1, V2, V3, this is classic presentation of the is called the arrhythmogenic right ventricular dysplasia. These patients can have sudden cardiac death until unless some appropriate measures are taken, for example, an AICD device insertion. So this is just to demonstrate in how the arrhythmogenic right ventricular dysplasia can be demonstrated in the defibrillator machine in front of you, even before you do a 12-lead ECG. This is something called Brugada syndrome. So this is another young patient who was brought in from Thailand to the emergency department, and he has got collapse at home. When he came to the emergency department, GCS was 15. We connected the patient to the defibrillator machine, and this is what we found. First of all, this is a sinus rhythm. There is a P wave followed by a QRS complex, P wave followed by a QRS complex, P wave followed by a QRS complex. If you carefully look at it, this QRS complex, it looks a bit Y. There is a bit of ST elevation, and the ST segment has got downsloping pattern, followed by an inverted T wave. This is found in case of V1, V2, or V3. This particular patient has got a V1 lead. This is called type 1 Brugada syndrome. You can have type 1, type 2, or type 3 Brugada syndrome. We have got a different video on the Brugada syndrome. We can discuss this later. Again, this is the patient who must not be discharged from the emergency department without any cardiology consult. This is a life-threatening emergency. Now, let me show you some other interesting cases that you can pick up in the defibrillator machine. This is a 56-year-old gentleman who has got a syncopal event in the shopping mall, and he was brought in by ambulance straight to the resuscitation cubicle. We connected the patient to the defibrillator machine, and we found this rhythm. What you can find here is that there is a QRS complex, a P wave, QRS complex, a P wave, QRS complex, a P wave. Now, if you carefully look at it, the PR interval is irregular. The PP interval is pretty regular. So the SA node is producing cardiac impulse in a systematic way, regular way. And if you carefully look at it, the RR interval, that is also regular. So the ventricular depolarization is happening at a regular interval as well. However, there is no relationship between the atrial activity and the ventricular activity, because the PR interval is not constant. This is called atrioventricular dissociation, and in this particular scenario, we will call it a complete heart block or a third-degree heart block. I've got a complete separate video on the complete heart block where I have described this in full details. Please watch that video if you would like. Now, what will you do in this patient? It depends. If the patient is hemodynamically unstable, and the first thing obviously we need to do is we need to get a 12-lead ECG, we need to identify why this is happening, and also we need to consider transcutaneous pacing. For transcutaneous pacing, we need to give some sedation, and then we need to obviously take the consent, give some sedation, and start on pacing. In transcutaneous pacing, we will press on the pacing button here, and then we need to set a rate. Usually I set at a rate of about 70 beats per minute, and then I increase the current starting with maybe 10 milliamp, then increased in increments of 10 milliamps. So 10, 20, 30, 40, 50, 60, 70, until unless there is an electrical capture and a mechanical capture. The electrical capture will be demonstrated on this monitor, and the mechanical capture is the palpable pulse and a recordable blood pressure. Once there is a capture, I increase this current another 10 milliamp above the threshold of the capture, and that is a temporizing measure of transcutaneous spacing. Obviously, these patients need to go to the ICU or CCU or cath lab for a transvenous pacemaker or an AICD device insertion depending on the local protocols and resources available. So this is a complete heart block. Never need to be missed. Now, this is a young patient, 26-year-old, came with palpitation, hemodynamic is stable, and when we connected the defibrillator pads, this is what we found. First of all, this is a narrow complex tachycardia. The QRS complexes are pretty regular and fast, and I cannot see any obvious P wave. This is called so-called supraventricular tachycardia or SVT. To be honest, I don't like the term SVT. I prefer either the atrioventricular nodal re-entry tachycardia or atrioventricular re-entry tachycardia. Again, we have got different videos to explain what is avnrt and what is avnrt. To keep it simple, we can call it an SVT or supraventricular tachycardia, which is demonstrated by these very fast QRS complex, regular narrow QRS complexes, no obvious P waves that we can see. Now this is a normal sinus rhythm. Again, look at the patient's pulse and blood pressure. If it is recordable, then we call it a normal sinus rhythm. So there is a P wave followed by a QRS complex. QRS complex is a narrow complex, followed by another P wave and QRS complex and ST segment and T wave. This is a sinus rhythm and it looks quite normal to me. Now what happened in this patient is, again, there is a P wave followed by a QRS complex, P wave followed by a QRS complex. So this is a sinus rhythm, but it is very slow. We call this a sinus bradycardia. A sinus bradycardia, and sometimes it can have a lot of different reasons. It can be myocardial ischemia, it can be drugs like beta blocker, calcium channel blocker, digoxin. It can be because of myocardial infarction or ischemia, myocarditis, cardiomyopathy, hypothyroidism, like mixed edema, coma. So there are a lot of different causes for the sinus bradycardia, and we need to identify the cause and treat it. This is a very interesting one. This is sinus tachycardia. It looks like the SVT, but there is a P wave in front of every QRS complex. So this is sinus tachycardia. Usually, we need to identify why there is sinus tachycardia. Is it because of hypovolemia? Is it because of some electrode abnormality? Is it because of some sepsis, myocarditis, some electrode abnormality? So many different conditions. We need to identify the cause and treat it. Obviously, this is not a shockable condition at all. Now, what is happening here? This is, if you carefully look at it, sinus rhythm, no doubt over that. There is a P wave followed by a QRS complex, P wave followed by a QRS complex, P wave followed by a QRS complex. However, the PR interval from the beginning of the P wave to the beginning of the QRS complex, that is a bit wide. It is more than 200 milliseconds. So this is a first degree heart block. A pretty benign condition. It can happen for normal physiological condition like in athletes. It can happen for some beta blocker, calcium channel blocker drugs. It can happen for myocarditis, myocardial ischemia, and also it can happen because of some structural problem like myocardial fibrosis. Most of the time, the first degree heart block is pretty benign. Now, what is happening here? If you carefully look at it, sinus rhythm, P wave followed by a QRS complex, P wave followed by a QRS complex, but there is one P wave which is not followed by a QRS complex. So there is some dropped bit. This is an atrioventricular block. If we get a little bit more detailed here, you can see that the PR interval is prolonged. There is progressively prolongation of the PR interval followed by an atrioventricular dissociation or drop bit. There is a P wave but no QRS complex. This is called the Mobis type 1 second degree atrioventricular block. Mobis type 1 heart block. It can lead to further complication like a third degree heart block, but Mobis type 2 is worse. And let me show you how Mobis type 2 looks like. So this is a Mobis type 2 second degree atrioventricular block. What you can see here is, again, there is a P wave followed by QRS complex, P wave followed by QRS complex, P wave followed by no QRS complex, so there is a drop bit. And if you carefully look at the PR interval, constant. PR interval is constant. There is no progressive prolongation of PR interval like in case of the Mobis type 1. So this is Mobis type 2. Mobis type 2 is worse. Mobis type 2 can lead to complete heart block, and this should be treated similar like in case of a complete heart block. So we need cardiology consult, and we need to consider putting a pacemaker if we cannot identify any reversible causes. So Mobis type 2 is worse than Mobis type 1. I've got complete different videos on the second degree heart block. Please look it up. This is we see this all the time. So this was a 56-year-old gentleman, came with palpitation, and he did not have any known medical conditions. He does not take any medications either. And when we connected the patient to the defibrillator machine, we found this. First of all, the QRS complexes are irregular. It's all over the place. Sometimes very fast, maybe around 200 beats per minute. Sometimes a little slow, maybe 100 beats per minute. There is no obvious P wave that we can see. The baseline is quite irregular, and this is atrial fibrillation. In case of atrial fibrillation, we need to identify a lot of things: patient features, demographics, previous histories, is there any thyroid disease, is there any electrode abnormalities, and then we need to find out should we do the synchronized DC cardioversion or not. This particular 56-year-old gentleman did not have any structural heart disease. He is otherwise fit and well, normal thyroid function, and the onset was just 10 hours earlier. We have given anticoagulant, and we perform a synchronized DC cardioversion. In synchronized DC cardioversion, we press the synchronized button here, and then we charge and deliver the shock after procedural sedation. In case of synchronized DC cardioversion, it is different from the defibrillation that we do in case of the VT or VF, in the term that we synchronize this so that the machine will detect when to give the shock or not. So if we consider the synchronized DC cardioversion, this is how it needs to be done. So at first we press the synchronize button, charge and deliver the shock after sedation. Similar to the atrial fibrillation, this is called atrial flutter. As you can see, the baseline has got multiple P waves, 1, 2, 3, followed by a QRS complex. And again, there are 3 P waves, 1, 2, 3, followed by a QRS complex. Then there is 1, 2, 3 P waves followed by a QRS complex. So this is atrial flutter. The QRS complexes are regular, and the P waves, they look like a sawtooth pattern. This particular pattern is treated similar way like in case of the atrial fibrillation. We need to identify the cause why it is happening and treat that. If sometimes it can be treated with a defibrillation with synchronized DC cardioversion after procedural sedation. Now atrial flutter usually comes regularly. In this case, this is a 3:1 block. So for every 3 P waves, there is 1 QRS complex. Sometimes you might find the heart rate is 150 and there is atrial flutter. This is 2:1 block. So for every 2 P waves, there is 1 QRS complex. It can be 4:1 block when the heart rate is 75. So that is atrial flutter, which is regular. Sometimes you might find atrial flutter to be irregular, but the difference between the atrial flutter with variable atrioventricular blocks and atrial fibrillation is that you can detect the P waves. In this case, as you can see in the baseline, you can see the P waves, QRS complex, P wave, QRS complex, P wave, QRS complex, P wave, QRS complex. So all over the place. Sometimes it is 1:1 block, 2:1 block, 3:1 block, 4:1 block. This is called atrial flutter with variable blocks. How do you treat it? Same way like atrial fibrillation. Identify the cause, treat it, and if required, we can consider synchronized DC cardioversion if the patient is anticoagulated and sedated. So these are the various types of rhythms that you can pick up very quickly with a defibrillator machine. If you have got any further questions, please drop me a line. My team will be very happy to answer to your questions. You can subscribe to my YouTube channel if you have not done already, and we'll keep you updated with new videos on hundreds of different ECG patterns, different tips and tricks. If you have got any further questions, you can drop me a line in the comment section below, and my team will be in touch with you as soon as they can. Thank you very much for your time. I hope that this session was useful. I will see you later. Thank you. Bye for now.